Hey friends, hi. Welcome to the second presentation of World of SLP, and the topic of discussion today is oral sensory processing disorder among autism. The topic is really vast, and hence for the ease of understanding it shall be divided into three videos. The first video is the introductory video wherein we try to understand what is oral sensory processing disorder, the neurological basis associated with it, clinical picture that we usually come across as an SLP, and finally answering a few questions which are based on this topic. The second video shall be covering entire assessment procedure, including the assessment tools, which are the standardized tools available, and the clinically easy methods that can be used, and special emphasis on the recent literature that has been done in this field. The last video shall be on the management of oral sensory processing disorder, which is within the scope of practice of an SLP. To begin with, let us answer one important question. Like as an SLP, how often have we come across the term oral sensory processing disorder? We usually come across the term of oromotor or oral motor, or the terms that are usually related to motor aspect. Sensory being in the field or in the scope of practice of an occupational therapist, we usually don't come across it very often, at least not theoretically. But practically, when you look at a child with autism, you see that there are symptoms which are very well manifesting about a sensory processing disorder. But at the same time, a sensory processing disorder is either added on or you see a cumulative effect because of the presence of a motor disorder as well. So it's not wrong to say that an oral sensory processing disorder and an oromotor disorder both can occur in a child at the same time. However, because of less amount of knowledge and because of less amount of exposure towards this field, we are unable to identify it as easily as we do for oromotor disorders. Secondly, autism is one of the conditions which is highly prevalent among children. We also see that there are other conditions like developmental disability, ADHD, cerebral palsy, mental retardation. These conditions are also prevalent. But yes, autism being the highest prevalent, and there is a recent literature and even past literature have suggested that the prevalence of sensory processing disorder, especially the auditory sensory processing disorder, tactile sensory processing disorder, is highest among children with autism. So it is imperative that as an SLP, we need to have at least basic idea about it, wherein if we look at a child, we at least know that this kid needs a detailed examination, needs a detailed help from an occupational therapist, and we do not further delay our referral. And hence this topic has been taken for the second presentation of our World of SLP. Come on now, let's just start this presentation wherein today we're just going to cover the first part as the introductory thing. We're going to talk about what is oral sensory processing disorder, how does it affect and clinically manifest. But it's a huge topic, and to understand it well, we need to have certain basics cleared about it. So having said from the basis of this thing begins right from the fact that, sorry, the basis of this thing right begins from the fact that oral sensory processing disorder. Let's just break it down. Oral meaning just the oral sense. Sensory, of course, talking about all the senses, and now coming to the processing part. Processing part is the major part that we need to understand because we haven't touched upon it of lately while. Now, what do we know about senses? We know there are 5 basic senses. We have mostly spoken about them. And yes, these 5 basic senses are smell, sight, touch, audition or hearing, and taste or gustatory. These are the 5 basic external senses. Why do we call them basic external senses? It's because these senses kind of keep us grounded with our external environment. It's with these 5 basic senses that we know about our position in the environment. We know about what exactly is around us, what is happening around us, and keep us basically grounded. That's the term I would prefer. But having little known about the other senses also, but they are of very, very importance. These are called the internal senses. When we say internal senses, these are the senses which are present inside our body, which are giving us input to our brain, and our brain is accordingly producing reactions towards these senses. So there are 3 basic internal senses also. First comes the proprioception. This sense tells us where is our body position and our body awareness. It's important. Whenever you look at a child who is unaware about how his hand is moving, how his leg is moving, and these things, it just clicks at somewhere this kid is unable to process his own body. The body map of that particular child is somewhere disrupted, and he needs help to just get that awareness about it. Vestibular we have studied, of course, as a part of our audiology subject, but vestibular, when talking about as an internal sense, is very important because whenever a child is on a swing, whenever he is doing something which involves a lot of vestibular input, you see manifestations of some of the extremely gross reactions, wherein the child will either have a fit of cry, he will be like he just cannot handle it, and these things are something wherein their vestibular system is just giving up. It's just not able to handle that stimuli. When we look at such children, it should ring a bell that somewhere these sensory things are not happening correct with this child. And last and least known is the interoception internal senses. These are the bodily internal senses which are not seen. These are also called as hidden senses, which is the internal physiological body condition sense. It talks about the pain that a person feels. It talks about the hidden feelings like a fear, anxiety, and all those things what we feel inside is because of some or the other input that our body is producing and causing these reactions. Now, having known about all the 8 senses and not just the 5, we are in a position that we can think about what goes wrong where, and we land up having a sensory processing disorder. But to understand that, we even need to know what is a sensory processing. Sensory processing is just a term which we will be defining very well in our later slides. But having said this, I would like you to understand that as an SLP, what do you think is the most relevant of the all 8 senses? Of course, I think the answer is very clear because we have already dealt with auditory processing disorder. We know that the auditory processing or the audition is one of the important ones. The other one, which is extremely important, is the gustatory or the oral processing disorder. Now, as I say this, it does not imply that it's just these 2 senses that we are involved, but a manifestation of these 2 senses is because of the accumulated effect of other senses as well. So, if a child is unable to chew something or is just having a cry reaction towards a particular food item, it is not just the oral sensory processing disorder which is affected. It is an addition of all the senses. As we will talk about it in detail, you'll understand. But within our scope of practice, even as Asha has given the guidelines, within our scope of practice, we do not have sensory processing disorder. So what do we do when we come across these children? So the prevalence rate of oral sensory processing disorder among autism is something we have spoken about. But the prevalence rate of sensory processing disorder is even higher. So whenever you will see the red flags, and you will be very precautious when we talk about this presentation, now you will know that these are the signs that a child will show you, and then that should ring a bell that this kid is having a sensory processing disorder. That's the exact time when you provide a referral to a specialist who can deal with these disorders, and that's nothing but an autist. Extremely important to handle these conditions, and a timely referral is extremely important because they are the ones who can identify not just oral sensory, not just auditory sensory, but an overall sensory processing disorder. Moving ahead, let us get our basics clear. So what exactly is sensory processing? Sensory processing is, it's a process in which the nervous system receives the message from the senses and they turn them into appropriate behavioral responses and motor responses. When I say appropriate, it is something that is usually expected. It is something which is normal, which is something which is highly prevalent among other normal kids. When we say abnormal responses, are those responses which we come across in children with sensory processing disorder. It is just my brain having undergoing 3 processes at a time. The first step that happens is registration. When I say registration, it need not mean that I'm registering only the novel things, only those things that catch my attention. By registration, it's simply when you're looking at this PPT, how many things are there which have actually stayed in your mind, and then you can recollect it later on. That is simply registration. Second step comes when you have to organize it. You have a lot of information in your registration. You have registered it. How do you organize it? and you organize it, you actually prioritize, okay, what was important, what was not important, okay, let me give this thing a prior in, position in my memory. Whenever a term like sensory processing will click, which part of the PPT should click up my head, example. And then the last stage comes wherein you're actually doing a processing. When we say processing, it's a whole system, a whole process which comes inside, but end product is that a child will be able, child or adult will be able to turn that input into a useful, into a favorable output or a motor response that is usually expected from him. Any step out of this goes for a toss or has a difficulty, the manifestations which you see in a child are something that you all have mentioned in your survey list, which I had sent. So why do that happen? Why does that happen? How does that happen? Is because in this whole thing which we just talked about, some step is there where the child is just having a breakdown and cannot tolerate it. We'll talk about it in detail because it's something which is interesting, and I think most of y'all will like it because it's a neurological disorder in which your sensory information it's perceived. It's not that the person has a hearing loss or he has a visual problem or he has some tactile agnosia, nothing. It's perceived, it's there, but the responses which are expected are not normal. Moving ahead, let us talk about the sensory processing disorder subtypes. The whole term is an umbrella term. Within that category, we have many subtypes. So the first and the most important subtype, very clinically relevant, is the sensory modulation disorder. When I say modulation, the concept of modulation says that whenever we are involved in some activity, there are inhibitory reflexes which are produced in our body, and there are excitatory reflexes which are produced in our body. Modulation is when my brain knows how much should I inhibit, how much should I excite, how to make that balance so that my response to that situation is something appropriate. Imagine you are in a situation wherein you get a lot of something, like a surprise thing. Your all your senses are just active, but your brain makes a calm, right? It takes some inhibition, it takes some excitation, and your reaction towards that situation is what your brain does. It's not something that your brain just throws it off and you're like, either you'll be like screaming around or you'll be like too much, nothing like that, right? So that's the process of modulation. Exact how much is needed, how much is not needed, and appropriate response produced. When this thing goes for a toss, of course you have problems, and that problems are manifested in three different types. Either you have sensory over-responsivity, also called as sensory hyper-responsivity or hypersensitivity, sensory under-responsivity or sensory hyposensitivity, sorry, hyposensitivity, sensory seeking or craving. Sensory seeking or craving, very, very commonly seen among autism. They are followed by the other two. Sensory modulation disorder in general is something which we come across very commonly in autism. Sensory based motor disorders are also there. Now, in this comes our different things that we observe in children with cerebral palsy. Sometimes we see in children with autism also. They have difficulty in stabilizing. Now, whenever I tell the child to blow a whistle, he has to stabilize that whistle within his lips. He has to stabilize his jaw muscles, his cheeks, his lung capacity. Everything needs to be stabilized for that one whistle to blow. At the same time, he has to get it moving also. So there has to be an appropriate and approximation, correct in correct amount, in correct, rhythm and sync. And lastly, to do all of this, the amount of planning that a child has to do is something huge. And whenever there's a breakdown between either stabilizing, moving, or planning, in a series of motor movement, then what happens is you see a disorder which is called a sensory-based motor disorder. The most common example for this is dyspraxia in children. Developmental dyspraxia is also one type of sensory-based motor disorder. And the last is the sensory discrimination disorder. Now the problem here is with sensing similarities and differences between the sensations. Now a child may be getting all the sensations, but he finds them all alike. He finds them, they are all just, either same or same stimuli are judged to be very, very different. It's just that he cannot perceive the changes, he cannot perceive the differences, and that's what causes this problem. Moving ahead, when we talk about sensory modulation disorder in detail, because this is highly prevalent among children with autism, we need to understand what exactly happens in the nervous system. So when I say it's a sensory it's a hypersensitivity or sensory oversensitivity. So your nervous system is over responding to the sensory input. So the input is the same what a normal child is receiving, what a child with autism is receiving, but a child having sensory oversensitivity, he will feel like, oh my god, that was something huge, and his body will be like thrown off in a fit. So it's that response which will be like too much for that particular stimulus. Sensory undersensitivity, as the name suggests, you are giving a fixed amount of sensory input which is enough to reach the threshold of that particular input, but somehow the nervous system is not getting adequate with that, and he needs more and more of it. So even a extreme flavor, an extreme taste sensation is something will not produce any reaction because the brain has not received enough of that sensory input. Last is sensory craving or sensory seeking. Now here the nervous system never seems to get enough or right kind of sensory input. When I say enough, it means like either their input is something they are craving for, but it's like they want it, they want it, they want it, they want it. They just keep on wanting it. And second is they are not getting the right kind of sensory input. Probably that their craving is for something which is textured, and they are constantly trying to put everything in the mouth which is of smooth surface, and they are just not getting that input which will settle them, which will make them feel good. And that's when they keep on putting every other thing in the mouth and they try to feel it. Having said this, what do you think is the clinical picture of sensory oversensitivity? Right now, we are just talking about in general sensory oversensitivity and not particularly about oral oversensitivity. So this child, when comes into your clinic and you're just assessing it, and you'll see that this child is overwhelmed. Even like slightest colorful thing, even the slightest noise, even the slightest amount of movement of the chair, something just jerks him off. It just makes him like, oh, what happened? Something like that. He's anxious. He's all the time under that feeling of panic that what's going to happen. If you tell this child to get up on the swing or to go onto a ladder, he'll be very cautious. He'll be having the fear that I will fall down. He'll be, overly cautious. He will not like the changes. When we say changes, it can be even a minute change in the room that can just throw them off and literally have a fit of cry. They just want it the way it is because their brain is just not ready to take it that way. That slight change also, the brain feels like, oh my god, this is something huge I have to deal with, and they just cannot tolerate the later on activities. And last is difficulty with transitions. Transitions can be from person, transitions can be from situations, transitions can be from activities. A simple transition wherein you are the clinician who is usually having a session with the child, but just because you're busy or something, and then the other clinician has to talk to the child for 5 or 10 minutes, sometimes these kids cannot take that also, and they will have a fit of cry after that and be like, no, like they won't verbalize it definitely, but their brain will be like, no, I just can't take this and it's difficult for me. The opposite of them are the undersensitivity kids. These kids, it's just not enough of whatever you do that their nervous system will register it. They'll be like, okay, fine, it's just there, but I am not, in that, my brain is not in that position to register it all, organize it and prioritize. Maybe you take this child in a room which is having everything different, something new, something novel, but their brain is at a level where the threshold is so very high that they just do not register it. You will see that they're inattentive. It's not that they're inattentive because of a component similar to ADHD. This inattention is that there's nothing, novel enough to catch their attention. When I am saying that I'm attentive towards something, it's something that has caught my attention. There's something which has engaged me. For them, this kind of motivation, this kind of feeling is not very commonly seen. They seem withdrawn because after a point of time, the brain also gives up. If you see that there is something which is not catching your attention, what would you do? You will be just withdrawn from it. You'll be like, forget it, I don't want to be a part of it. They have difficulty to engage because none of the activities trigger their nervous system enough. They are slow to respond because sometimes they need that much amount of input so that their nervous system actually registers it and gives an appropriate response towards it. So they take their own time to respond. Their activity is low, they prefer sedentary activities because even doing a heavy work or even doing something which is very very sensory loaded is not enough for them. So they prefer a sedentary life, and those activities which involve screen and which involve less of the movement are something which they look. The last and the most important one is the sensory seeking or craving. These kids are the ones which usually, if a layman would label this kid, it would be called as a naughty kid or someone a kid who does not have any sort of control over himself, because he will be like all over the place. This is the kind of kid sometimes misunderstood as an ADHD child, because the manifestations are similar. But if you look closely in your assessment, you will realize that there are certain typical features that a sensory craving or sensory seeking child will exhibit. Firstly, they will have lack of safety awareness, and this is very common. They will not have that thinking of, if I just climb up the stairs and I missed out a step or something like that, what will happen? If I just go and touch something which is very, very hot because I feel like touching it, what will happen? They will not have this thing. Also, this can be regarded that they do not have the cause and effect relationship. But at the outset, if you have the list of sensory seeking symptoms, you can easily identify whether it is a cause and effect relationship which is lacking, or is it the actual seeking behavior the child is exhibiting. Impulsive, he'll obviously blurt out before his turn, he'll try to pull things, he'll try to take everything. That's how the impulsivity is manifested. He's constantly moving. It's constant moving is something wherein the child is constantly trying to get some sort of vestibular input, some sort of, proprioceptive inputs, wherein some stimuli he comes across and he'll be like, okay, fine, this is something which is giving me a calming response, a settling response, and that's what he's constantly touching everything. He's trying to explore everything around, and that's when you see that these are the kids who will take away any toy that you give him, put it in their mouth, just because they want to feel it. They want to get that input, which you and I may be getting just by talking. You and I may be just be getting by touching. But for them, it has to be to that level when they put it in their mouth, they explore it, and then they understand it. Now, just taking that whole concept of oversensitivity, which was sensory oversensitivity in general, let's just put it in our clinical picture of oral oversensitivity. This is what we come across when a child has oversensitivity. Now, just at this point, I would like to share that whatever responses I have received from the survey that I did before the start of this webinar, you all have mentioned about various different conditions that you come across when a child has this thing. While I go through these slides, I would like you to think about those symptoms that you have, come across, and try to fit your child in either of the categories. Is your child of oversensitivity? Is he of undersensitivity? Is he of craving? These are the most common ones that we'll come across. And the symptoms also I've read through, which you all have shared, most of them will fit in either of them. Why I'm saying this is because when you will fit them in a particular category, you will realize that your approach towards that child will be very different once we are through with the entire topic of this discussion. But yes, it's important to understand these three different things, because what we try to do for that kid may not be suitable because of the underlying symptom that he has. It manifests as, for example, oral oversensitivity manifests as all these things. For example, let's take the first one, food jags. Food jags is that he has a very narrow repertoire of food. He'll just like either a particular type of food or a particular consistency or texture. That's a very narrow thing. He will gag at the sight and the taste of certain food. Even just by looking at it, you will see that the kid has a gagging response. He will prefer pureed or bland food. He will not like, those ups and downs of different tastes, sensation that will just give a blast to his head. He will not like it. He will dislike mixing of food or textures, because that is something which is overwhelming to his nervous system. He cannot handle that much. He will avoid messy play. Messy play will be anything, even with water, even with clay, even anything that will, will give him additional tactile input, additional of that, wetness and anything. He'll not like it. And have a strong aversion to brushing. Even the fact that you will try to touch the teeth while doing an OPME is something they will avoid it. They will not like it. They have this aversion behavior in general. And it's just that your single touch also makes their brain go like, whoa, what is that? I don't want it. They have abnormal manner of eating from spoon, and the most abnormal manner is when the parents will tell you that when I put the spoon in his mouth, he doesn't take it with the lips. It's just the teeth part and it's pulled out. That's the commonest thing, because they don't want that stimuli to touch their lips and get that additional of input unnecessarily, to make their nervous system even more highly sensory overloaded. They will turn away from food. This is true for the food that they are not comfortable with, they are not liking, and they are just aversive towards. And the resisting can be of any form. They will have different behavioral problems. The simplest one is by saying no. by crying, by kicking, by screaming, by any other undesirable behaviors. Depending on where your child is, you can have any of these reactions. And talking about sensory oral undersensitivity, these are completely on the opposite of the spectrum. So these kids are the ones who will not just realize that there is something in my mouth. They will drool. They will have drooling, which is uncontrollable. The reasons behind drooling. Now, drooling was very commonly, even in the survey, I found that drooling was very common with what you all have suggested. But I would tell you that drooling has a lot of other reasons as well. One of the reason is oral undersensitivity, wherein drooling is there because the child is just not conscious about the saliva in the mouth. He's just not aware about it, and it's just flowing. It's just flowing with the poor lip seal. It all comes out, and that's one of the reasons why it happens. Spitting of saliva is because it's just too much after a point, and they feel like spitting it out. That's one more reason. They are unable to feel the food around and in the mouth. This is the most common thing that a parent will tell you, that he just keeps the food in the pockets. It's just that he doesn't do anything about it. And then there is overstuffing mouth while eating, because little just doesn't give that input. So let me put a bigger piece, let me try a bigger piece, let me see how it happens. If you give them something smaller, they'll be like, no, I don't want it. As opposed to the oversensitivity, they're okay with that smaller ones. These are the ones who will be like, no, I want the huge piece. Maybe that will give me the input that I want. And they're messy eaters. Messy eaters means they'll try to get as much possible input from that eating, that food item on their hands, on their mouth, around the lips, in the mouth. They try to get, they'll seek literally that, okay, fine, I want it more and more, so that maybe it triggers it. And then they have underactive gag reflex. And it's just not enough for a simple stroke on the back of the tongue or a simple stroke on the posterior pharyngeal wall to elicit a gag reflex. They have difficulty in learning to use straw. This also has a basis on oromotor aspect, because their oromotor skills are poor, and hence they have difficulty in learning how to use a straw. They have this common thing that the food will accidentally fall out of the mouth. They're just not aware about it. That there's food lying here, there's food lying in my cheek, the area between teeth and the cheek, and then it's just. When we talk about oral seeking, now we move ahead and we talk about oral seeking or oral craving. So these are the symptoms where the child is constantly trying to seek a texture, a particular type of sensory input that will help him calm himself. Most of them are trying to find a particular texture and that feeling which is with that sense. And that is the reason they will go on licking the objects, they will go on biting the objects or chewing them, just with that tendency that maybe this particular stimuli will give me that amount of sensory input that is making me calm myself. So that is the reason you'll see that they are licking toys, they're chewing the objects, they're biting the toys that you give. Also, for a fact that teeth grinding is a symptom which has a lot to do with the kind of input they receive from their jaw muscles. When they receive that input from the jaw muscles, it kinds of soothing, it's a soothing response, and hence they keep on doing it again and again. They have this craving for flavor extreme, so they will be liking those flavors which are like too spicy or too sweet, too sour. Spicy is obviously less expected, but the sweet and the sour are the one which they will like a lot. Biting fingernails is something when they're too much overwhelmed with the sensory stimuli around, they just cannot cope with it, and that's when you see the behaviors of biting fingernails also. And they love condiments. It can be simply like a sauce or a puree or something which is just the spices also, but they will like it really a lot. Now, having known about oversensitivity, undersensitivity, and seeking, it is easier for us whenever we see some of the symptoms in our children with autism to understand and we fall into which of these categories. When we understand that, okay, fine, he is from this particular category and this is the problem he is facing, we can take an appropriate approach towards our assessment, towards our management. Because sometimes just by being unknown about it, we tend to give some of the treatment options which are not actually helpful for them, but it will even worsen their condition unknowingly, and just by the fact that looking at the symptoms we try to do that, and that happens very often with us also. But there is a point where we need to realize that when do we call it as abnormal. It's not abnormal if you see a child of between 0 to 2 years of age trying to put everything in the mouth, trying to explore everything. that's when you realize that, okay, fine, it's just the normal sensory motor development that a child is undergoing. And during this stage, he will do the n number of activities just to explore the environment, just to take that feel from that. And past the 2 years of age, when these behaviors persist, that's when you feel like, okay, fine, he must be undergoing some sort of sensory processing disorder. Now coming to the main part, that as an SLP, these are all the symptoms that we come across clinically relevant to us. Are these all? The most common of them is the licking and chewing of the toys or inedible things, followed by drooling. We often come across kids who will do biting of their sleeves, collars, and other toys also. They will put colors, play-doh, and especially the small beads in their mouth. And spitting is something which we don't like from the top to bottom. As we move down the list, we go down in hierarchy. Then the first one is the most commonly seen, followed by the rest. Teeth grinding often seen, and verbal stimming also very commonly seen. But verbal stimming and teeth grinding, both of them, teeth grinding we have spoken about, but verbal stimming is also a kind of soothing reaction that they get. So it's that particular movement that we constantly try to do. It's even auditorily soothing them and also orally also soothing them. Now, to make our understanding clear, to help us in talking to parent, answering their questions, we need to understand a few of the neurological basis of oral sensory processing disorder. I wouldn't call it neurological basis per se, but these are the probable causes or probable reasons why this child is exhibiting what he is exhibiting. So most often you see the parent asking you that, I don't understand, why is my kid always trying to put everything in the mouth? Why is my kid, trying to, avoid certain food items? So if we have an idea about what is exactly happening, I think we can, suggest them better strategies to deal with. So one of the reasons why it is happening is developmental delay. Now, a child who undergoes from 0 to 2 years a normal sensory motor development, he tends to do it within that age bracket, that is still 2 years of age. If the same child is having some amount of developmental delay, then this 0 to 2 years gets pushed behind. So we are comparing the chronological age and the developmental age. You realize that he is undergoing the normal developmental series only, but it's happening at a different chronological age. So it's a reason why he's exhibiting those symptoms which he should have ideally exhibited at between 0 to 2 years of age. Second, some of the stimuli are alerting, some of them are calming. So it's that feeling wherein some child might just feel that there are certain stimuli that are alerting him. That is, it just kind of gives them a feedback, which is a flight or fight response, which happens in our sympathetic and parasympathetic nervous system. Some of them make it to an alerting level, which they try to avoid. They try to, have a strong negative feeling associated with it. And some of them, on the other hand, are the calming effects. And those things are the one which will make them feel better, make them feel, do that particular activity again and again. It's a phenomena wherein some stimuli create a sense of relaxation in the brain, and those are seeked or craved time and again. And the other stimuli are creating an impact of anxiety, fear, or nervousness, and these are the ones which are avoided, or those which are having a strong aversion towards them. Other reason behind it is sensory dysregulation. When we talk about regulation, it is basically a feeling where all the senses are giving the input, my brain is analyzing it, it is regulating them in a manner that my output is not affected. When a child is having a lot of sensory stimuli around him, what happens is it takes a while to register them. So any normal child also takes a while to register them, organize, and then process it. So their brain is trying all the time in that up and down procedure that, okay, fine, there's a lot of light in this room, there's a lot of taste, sensation coming from this particular food item, there's a lot of noise in this room. So any normal child will take a while to settle in that. Once the child gets settled, we can say that the child is regulated. Of course, regulation has two different types, where the child has a self-regulation also, and there is co-regulation also. Self-regulation, wherein the child himself tries to balance himself, and the brain is, helping him do that. When we talk about co-regulation, it's when you do it with a child. So the child tries to mimic his adult parent or clinician or someone, and he tries to co-regulate himself. But this procedure of regulation in general, self as well as co, is difficult in case of children with autism. So they are unable to complete that whole process of sensory processing, and it's either a breakdown at the start, at the center, or somewhere. and hence that cycle is not completed of sensory full processing, and regulation never is achieved just by themselves. That's the point where you realize that this brain is giving up this particular point, and that's the step. That's the point where we need to step in, help him achieve that step, move ahead, and complete that entire cycle of sensory processing, make him regulated, and then move ahead. Most important, sensory overload is one of the phenomena where it's an inability of the brain to cope with the multiple sensory input, leading to a breakdown. There are two wonderful videos on YouTube, the link I'll be sharing with you all. It has a description or depiction of how a sensory overload would work. When we talk about sensory overload, we most often we also don't realize that when you are taking a child with autism, it somehow happens that sometimes it's not possible to control all the factors, but there are certain things in the room itself that is creating so much of impact on him that it's just too much for him to take. It can be as simple as a red color in the room. He's unable to take it and he'll be like thrown off with it. It can be as simple as the ducting sound made by the AC. Can be even as simple as the creaking sound made by the door. These are very little things which can make them feel like, oh my god, there's too much I have to handle. And just because he's just unable to handle, so what he does is he resorts to some of the behaviors like constantly moving around, constantly trying to seek some of the things. And that's when you see that, okay, fine, this child is just not able to manage here. Many of the other behaviors that he comes across because of sensory overload is he'll just be like, I can't handle it, and either he'll be on the extreme end wherein he'll be quiet, not engaging at all, or he can be at the other extreme end wherein he's just too much difficult to handle that particular child. He'll be like, he'll either try to seek some of the sensory input that is soothing him at that point. So that's when you realize that it's not maybe just the plate of food that you have given it to the child, it's n number of things in that particular environment that is creating that overload. Having understood all of this, we reach to the concluding where we have a lot of to understand. So we have understood what exactly is sensory processing disorder. We have understood what are the senses that are involved. We try to understand what are the clinical manifestations, not just of oral sensory processing disorder, but otherwise sensory processing disorder also. Also, we try to understand that how a child manifesting a particular symptom, what exactly is happening at his neurological level, what exactly is the reason behind his manifestation, and finally a clinical picture of oral sensory processing disorder. Now, with all these knowledge, we obviously now know that a symptom which a child exhibits, there is a reason behind it. So even before we move on to assessment procedures or management procedures, always remember that a particular behavior exhibited by child is not just a symptom or a behavior. There are thousands of things, thousands of reasons which are behind them. If and only if we'll understand why these behaviors are there, we'll be able to help the child in a better way. Moving ahead now forward, we have two more presentations wherein we'll talk in detail about the assessment procedures which will have the standardized as well as the clinical techniques. Finally will be the management. In management, we'll place a lot of emphasis on the recent literature because definitely the traditional methods we all are aware about, but the recent literature also needs to be spoken about. If you have liked this video, do share it with your other SLP fellows, and you can subscribe to the YouTube channel because it's going to stay there. And yes, it's also there. The link of that YouTube channel shall be shared on my Instagram page. Soon we'll be uploading the videos on assessment and management. Feel free to ask any questions in the comment section and also give your feedbacks. Thanks a lot. Looking forward to many more such videos. Thank you.